Good morning, everybody. Welcome to Grand Rounds. Great to see everybody. Not sure about where you guys live, but we had our first monsoon last night at my home, which for me is one of the great silver linings of Phoenix summers. I think we have a great lecture this morning. The topic is adverse childhood events, and our speakers are Dr. Funda Bachini and Dr. Lara Yoblonski. Dr. Yoblonski is a graduate of Northwestern University in Chicago. For medical school. She then did her residency here at Phoenix Children's in Maricopa Medical Center and did a chief year as well. She's worked in a number of settings, including being a hospitalist at Maricopa Medical Center. She's worked as private practice pediatrics, and then most recently here at Phoenix Children's for the last 6 years has been in the homeless youth outreach department. And then Dr. Funda Bachini graduated from medical school in Philadelphia at Drexel University. She completed a psychiatry residency and then a fellowship in child and adolescent psychiatry at Maricopa Medical Center. And since 2015, she's been here at Phoenix Children's, and she is the inpatient medical director for the child psychiatric unit here on the 5th floor. So please welcome Dr. Bachini and Dr. Yoblonski.
Okay, thanks for coming this morning. Appreciate you guys getting up early. Let me see if I can figure this out. There we go. Okay, so our objectives today are going to be to talk about trauma-informed care and the basic underlying tenets of that, to understand how patients' social determinants of health can affect their health, and then discuss some practical ways to incorporate trauma-informed care into your practice. And just so you guys know, when we're talking about trauma today, we're using a much broader scope and definition of trauma than what we sometimes think of as our physical trauma. So just use that lens while you're thinking about what we're talking about today. We have nothing to disclose.
So we are going to start with a case and kind of build on that as we talk about this. So this is Yvette. She's 12 years old. She's recently been discharged from her 5th inpatient hospitalization, and she's coming to see you in your clinic. She comes with her guardian just for a checkup. But while there, the guardian has a lot to say about her behavior. So she reports that the patient's behavior has been challenging, that she is defiant, that she has an attitude problem, that she's been starting to throw fits, especially when a new person enters the home, and then also when they leave. So you listen to this, you're being empathic, and you can see that Yvette during this process is getting a little bit riled up. So she's tensing up, and as you go to do your physical exam, she gets increasingly upset. So she's disputing what the caregiver is telling you about what's happening, and eventually escalates to the point where she's banging on things, she's throwing things, she's ripping things up in the office. So as you look at her, I'd like you to think about what you would do. So what would you do if you were the provider, right? You're the pediatrician in this scenario. And what would you do if you were her, right? So if you were at the doctor's office and your significant other is with you talking about, well, they never wear their CPAP and he never does anything I ask him to. I have to ask him 15 times. What would you do? And what would you want to do? And as we talk about the brain development with trauma, think about what are the mechanisms that maybe prevent you from doing and saying the things that you'd really want to do in that situation? And if Yvette has all those resources at her disposal. So when we want to understand her and kids like her, we have to know a little bit of their history. So Dr. Yoblonski is going to talk about that.
Okay, so I wanted to give you a little bit more information about Yvette. Now we're in the primary care setting. First column is your first visit with her. She's a new patient. She's a 5-year-old female. She's with guardians. You're running a little late, so you don't quite have time to tease out that whole relationship. They don't really know any past medical history about her. She's been coughing a lot, and somebody at some point mentioned the word asthma. She's underweight. When you listen to her, she's wheezing. She appears to have some developmental delays, and her vaccines are delayed. So this is kind of, a visit that many of us have had at one time or another, and you kind of have to just get through it as fast as you can. And you go ahead and you get her asthma treated. You go and give them an inhaler and talk about asthma treatment plan with them. You send them to behavioral health because of some of the developmental delay and some behavior issues that they're bringing up. Give her vaccines, and then you're going to follow them up in 2 months. So in 2 months, they no-show. Again, not completely unusual. This is something we see regularly. They come back in for her 6-year-old visit. Again, she's with some guardians. You can't remember if it's the same guardians or not because it's been a year. She still has a cough. Now they're talking to you about some issues in school. She's having some behavior problems at home. She's very nervous sitting in the room. She's now overweight on the BMI scale. She's still wheezing. Developmental delays have really not been addressed. So you go ahead and do what you do. You refill her asthma meds, because that's something we can get done today. You talk through nutrition in 95210. And you, again, consult behavioral health and talk to the family about the importance of following up for these issues at school so that school doesn't become a problem. Again, they don't show up for the behavioral health appointment, and you try to call them because this has been the second no-show at behavioral health, and the phone number is no longer in service. So the next year, they come in for a well check, and they let you know they're there because the insurance company called them and told them they needed to get their well check done. She's now with group home staff, and it's not a group home you're familiar with. They don't have any medical records for her, but they do know that she has seen you before. They're concerned because she's having trouble in school. She's having complaints of her vision, and then this cough that she's got. Again, she's overweight. She's wheezing. You go ahead and refill her inhaler. You do another behavioral health referral because that has all fallen apart when she moved to the group home. And you do her vision referral because, again, you can at least get that done today. And what you find out is she continues to have problems at school and at the group home. So they come in several years later for another well check. She's still at the group home. She's now on Zoloft for depression. When you do the depression screen that you do, because you're a good pediatrician and we're supposed to be screening for depression in teens now, she's positive. And on your questioning, she just says, I'd be better off dead. So this is the middle of the day. You've got a whole bunch of patients coming in. What are you going to do? And as we all know, life is busy, clinic is busy. These are big issues when they come up in the middle of clinic. And frankly, they're big enough issues that a lot of times I think we hide from them because trying to deal with this in the middle of a day is really hard. So you do know that there is a crisis team that you can call, so you call them. The family has to sit and wait in the office for 3 hours while the crisis team comes. Or I'm sorry, the group home and the patient have to sit and wait. When they get there, they do assess her and feel that she is suicidal and feel that she needs to get admitted. So she gets admitted to the psych unit, and that's the last you hear about it. So you don't really get any follow-up. And again, you just, you're tapped out. You don't have time at this point to try and get the records and follow through on all of this. So the next thing you hear about her is when you find out that she's now on her 5th admission to the psych unit. So have any of you seen a patient that is similar to this at all? Hands? Yeah. Like, this is not an uncommon patient for us. Oops, sorry, that didn't work. What are some of the barriers to care that you guys can identify with this patient? Yeah. Yeah, and that's a huge problem for primary care. Just trying to find out if they showed up, let alone what was done, is always a big problem. And then because the systems are almost run in parallel, it seems like, and we don't get a lot of cross communication. And you'll get randomly these one-pagers from, whoever is the behavioral health group that say, you've been identified as the PCP, we did a med change, we're sending them back to you. And it's kind of like, well, what happened? I don't even know the diagnosis. What's some other barriers you see on this? Yeah. Right. Exactly. Medically, she's got some asthma, her weight's up. I mean, we do that all day long. That's not super complex, but her life surrounding her is very complex. And a lot of times we don't take that into account, and it's hard to bill for that. So it's a reality of the way we do medicine. The other thing I'd bring up is that the way that our system works in Arizona, and most systems actually, being in DCS custody foster care group homes, there's really fragmented care. They'll see multiple providers at any one time, and there's very little continuity between provider to provider. So trying to get a medical history is always a challenge. So what do you think about this type of management? Is it the kind of management you want to do? I mean, clearly I think we can all agree this is not the ideal situation, but it's what we do every day, and it's what the psychiatrists take care of on a regular basis because the system is not working. And then the other question we wanted to ask is, how does this hurt us as providers and staff? How does it hurt our staff? So just something to think about as we go through the rest of the discussion today. I'm going to turn over to Frida.
So to understand what happens with these kids, this patient and all our patients with trauma, you really have to take it back to their early brain development, right? So our brains are incredible. You have 86 billion neurons. You have trillions of synaptic connections. Our brains are adaptable and amazing. So we look at a critical period of development, and we consider that to be birth to about 3 years of age. So we know that a lot of our development has this type of critical period. For example, we're all born with the ability to make all the phonetic sounds for all languages, right? But if you don't learn a language when you're young, even if you immerse yourself as an adult, you have an accent because that critical window closes. Birth to 3, we look at attachment, at relationships, at laying down our template for how we perceive the world around us and our relationships with people. So it's a really pivotal time. There is neurogenesis, synaptogenesis, differentiation, all these things going on at peak levels during this time. And the pathways that are used more often are the ones that are strengthened. So when you're a baby and you cry and your caregiver comes and holds you or feeds you and changes you, you form those neural connections that tell you the world is a pretty safe place. I can trust people. I don't have to be alarmed all the time. I can relax. If you grow up in an abusive relationship, environment, or neglectful, this does not happen in that way. So with trauma, and we have to differentiate trauma from stress. So this is one of those interesting things. Stress, a lot of things are stressful, right? So speaking up here can be stressful. You have deadlines coming up. You have 25 patients to see in a day. If you have stress and you're able to respond and overcome and be successful in the face of that stress, that builds resilience. That's something that our brains actually need. If, however, the stresses are too much and your coping skills and your resources, such as family, friends, are not able to help you overcome those stresses, then it becomes traumatic. So you can imagine as an infant, if you are crying and nobody comes, or if that care is inconsistent, right? So when mom is sober, she comes, and she's using, she doesn't. That creates an unpredictable environment, and becomes traumatic. And in the face of that repeated trauma where you never come back to baseline in your arousal systems, your brain becomes sensitized. So then the littlest trigger can cause you to go into fight or flight or freeze, because those are the neuronal pathways that are reinforced. So these are some pictures. So not only are the neurons themselves damaged with toxic stress, but you have fewer neuronal connections. And then you have just decreased brain activity. So it affects the development of different regions of your brain and the interconnectivity between those regions. The brain develops bottom up, so you start from your brainstem, right? So when you're born, a lot of these functions of the brainstem are already working pretty well. You're swallowing, you're breathing, right? Those things you just do automatically. Your neocortex doesn't fully develop until your 20s. The issue is that this is like building a house. So if you look at the parts on the bottom, your brainstem that houses important nuclei for your neurotransmitters, like the reticular activating system that then sends projections to the rest of your brain, if that framing is not well developed and organized properly, then the rest of it cannot be organized. So if you use that house analogy, if you put up the frame of the house and it's crooked and not done well, then it doesn't matter if you put the rest of the parts on the way you're supposed to. The overall system is not going to work. So that's what we see in these kids. So when they are presented with a perceived stress, that again can be something that we wouldn't recognize as a stress because our brains are wired differently, their neocortex is not going to work. They are going to be all in brainstem, and the more we're like, well, this is not how you're supposed to be acting, and now you're going to lose this privilege, they are not receiving that information because they are operating at a very primitive level. Our brain also develops from simple to complex, and this is just a variation on that same idea. So if the things that are supposed to happen first don't happen well or happen in a disorganized fashion, then the rest of it can't happen. So what we see with our kids that have been through trauma is even though their chronological age may be 10, 11, 12, they are unable to act like a 10, 11, 12-year-old emotionally, especially when there is some sort of perceived threat. So when someone is sitting in the doctor's office with them, talking about all the things that they are doing wrong, their red flags go up, right? This is dangerous. Something bad's going to happen. And they respond to that threat. Like I said, our brain is built for adaptation, and so you have things that affect the neuronal structure in early development, but you also have things that affect the epigenetics. So this happens in utero and after, right? So genes get turned on or off or regulated up or down depending on the environment. When you look at the differentiation of neurons, for example, they do that in response to neurochemical signals, right? So if your brain is doused in cortisol, if you are always stressed, then they are going to adapt and respond accordingly. There's really interesting studies looking at the epigenetics in utero and maternal stress and what happens after that. This is one of many studies that notes that there is a difference in methylation of genes in kids in foster care who have some sort of abuse and those who aren't, but there's many other studies like this. So when we talk about things that affect development, that affect our epigenetics, we have to talk about ACEs. So how many of you know about the Adverse Childhood Experiences study? Awesome. That's good. So this was a study done by Kaiser Permanente and the CDC in 1998. It was originally an obesity study, but what they noticed was that some of the people in the study, even though they were losing weight, were being lost to follow-up and dropping out. And when they went back and found those people and took more in-depth histories, they saw that a lot of them had some sort of abuse. So the ACEs study looks at these 3 categories, but we know now that there's other stressors, right? There's things like bullying, there's discrimination, there's living in dangerous environments, there's food insecurity. These are just the ones that the ACE study looks at. So we consider 4 or more ACEs to be high, and it puts you at risk for not only poor psychiatric outcomes, depression, anxiety, substance use, but physical outcomes as well. So increased rates of obesity, heart disease, diabetes. So it becomes really important. These are our ACEs in Arizona. So 4 or above is what we consider high. As a state, we are above the national average in ACEs, and 30% of the children in Arizona have 2 or more ACEs. So kids with 5 or more ACEs would fill the football stadium here, right? And we rarely assess for these issues. And then when we find them, we're left with limited resources to address them. So something that I don't have up here, but I always say when I give these kind of talks, because it's so like mind-blowing to me, is that Arizona is consistently in the top 10 for funding of mental health services. We are 49th and 50th for adults and children in the delivery of mental health care services. So for our kids, having their ACEs be so high and their resources be so limited, it's especially important that, you know, as pediatricians, sometimes you're the only people that they see. So to be aware of your interactions with them becomes especially important. So these are our kids, right? So their first hit is that fetal programming, the epigenetics, and then they have early life stress. They're faced with adversity. That affects their physiologic symptoms and processes, which then results in more stressors, right? Because now they're getting in trouble at school and they're blowing out of foster care placements. And then it ends up with chronic disease and psychological functioning. And then if you look at maternal and fetal health, that goes back up transgenerationally and we start again. So the important thing to do is intervene in this cycle in a way that we get kind of the most bang for our buck in terms of helping them. This is what we do now. So what we know about the brain's capacity for change is that it's greatest when you're youngest. And there we do Head Start. And as the ability of our brain to change decreases, we ramp up the time and money we spend on services to help people change their behavior. So this system is really backwards. We wouldn't need so much substance abuse treatment and juvenile justice programs if we had extended maternal leave, paternal leave, if we put more energy into the kids when they're young, because that's that critical phase. That's when we have the most impact. So what can we do about this as providers? You have all the answers, right? I hope you're coming up here to tell them what to do.
So that's the end of our talk. No. So now that we've depressed everybody, the good news is there are some things we can do. First of all, the answer, as Funda very succinctly put it earlier today, is not that hard. It's to have healthy, stable, consistent caregivers in our kids' lives. And that's where we come in, because we provide a lot of information for parents and caregivers and guardians and foster parents about what to do and when to do it, and when to raise the red flags, and when we can kind of try some different things at home. So that's, as pediatricians, that's where I really see our role in this, diving into this issue. We can really support them in making the hard decisions and doing the hard discipline type things that are going to need to be done for a lot of these kids. Secondly, we can advocate for changes in our system. I think we all can probably agree that there are definitely things going on with the way we do medical care today that are not real rational and need to change, especially with Arizona. And so there's things that you can do within your own practice, within the hospital, within the state, within the city. So just try and think about some of those things that you can change within the 5 feet around you. So what we're going to talk about today is one thing that you can do. It's called trauma-informed care. Trauma-informed care, instead of asking what is wrong with the patient, so what's wrong with you? You're overweight, you have asthma, you have behavioral problems, and you have difficulties at school. Instead of approaching it that way and building our problem list like we normally do, approaching it as what happened to you. So if you looked at our patient and you kind of said, okay, so you have asthma, you have obesity. I know both of these tend to be chronic problems. I wonder if there's anything triggering both of them. I wonder if the cortisol level's been high for a long time with this kiddo. And then you look at the behavioral health and the school difficulties, and you start putting that piece together, and you're able to take a little more time, find out what's going on, why are there guardians here instead of mom and dad, et cetera, et cetera. If you can start teasing out those threads, we may be able to more effectively approach this patient instead of kind of going down the path that we went down. The other thing about trauma-informed care, I kind of feel a little bit like I'm preaching to the choir sometimes, especially when I'm talking to pediatricians, because this is stuff you guys do all day long. You inherently do this because taking care of children kind of invokes this in us. When you are examining a child, especially a 2-year-old, and you leave them on mom's lap to get a good heart exam because they're going to scream and kick you if you take them off her lap, that's trauma-informed. You're doing what that child needs in that moment to feel safe and to allow them to build a trusting relationship with you. Because once you get done and you give them their shots and they're mad at you, you can then bribe them to trust you again with toys. No lollipops, but toys. So first of all, I just wanted to go over definition of trauma because I think a lot of us don't have a clear understanding. I did not. Individual trauma results from any event that, or series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning, mental, physical, social, emotional, or spiritual well-being. So it's super broad, which I don't do well with. I kind of like it cut and dry. But the takeaway point from this is the trauma is in the eye of the beholder, not in your eye. Does that make sense? So what could be very traumatic for me and something that I carry with me for years and years and years may not be traumatic for Funda. And she may have a different set of resiliency factors, or she may just not have had that experience be traumatic for her. Whereas I take it on and carry it, and it's a chronic stressor for me. So you have to work with the patient to identify what the traumatic stressors are for them and how they respond to them. Just because a kid was physically abused does not mean that they're going to develop bipolar depression and anxiety. And we all know that. We've all seen those kids who thrive despite the circumstances. And it's trying to figure out what are those factors in those kids that really help them thrive and grow. The other thing about trauma is that, as Funda was talking about, we have stress that's good, we have stress that's bad and becomes toxic. We also have stress that's acute. So an event, your family gets in a car accident, it's a traumatic event. Many of the kids we're talking about and dealing with have chronic stress, and so it's every day. They go home and they have no idea what's going to happen when they walk in the door. Are they going to get hit? Are they going to get yelled at? Is there food? Is mom getting hit? So every day is an unplanned event, and a lot of their behaviors, when you stop and look at what they're doing, especially in the room when you're going to give them shots, you can see how those behaviors have become adaptive and become survival mechanisms for them. And so it helps you kind of figure out different ways to go about giving shots or different ways to go about doing your exam. AAP has actually identified this as a significant issue in pediatrics, which is always interesting to me because this came out in 2016, I think, and very few people really have heard about it or know much about what we do with stress or toxic stress. My hypothesis behind that is that because we as a community don't really know how to get them to the services we need effectively. And so AAP does address some of that. So it's an interesting guideline to read through. And then also on the AAP website, there's a ton of stuff about trauma, toxic stress, how to deal with kids that are in stressful situations. They have a really good toolkit and a lot of takeaway information you can use. So trauma-informed care, again, this is a long quote. Long story short, what it says is that organizations that are providing trauma-informed care realize that there is widespread trauma, which I think we've established there is in Arizona. There is recovery from trauma. You can do that with good support systems, services, and behavioral health therapy. And it recognizes that trauma affects clients, families, staff, and others involved with the system. So it's not a one and done thing. This is a pervasive thing that goes throughout our systems. And then they seek to change it and address it by fully integrating things into their systems, policies, and procedures. So I just kind of wanted to take it out of the quote, make it a little more simple for you. So systems that offer trauma-informed care, or practices that offer trauma-informed care, or providers that offer trauma-informed care realize there's trauma, they recognize the signs and symptoms of trauma, not only in patients but in each other. They respond to the trauma, and then they resist re-traumatizing patients. I don't know how many of you in your care have gone home at the end of the day and been like, not only did I not do any good, I kind of feel like I may have done some bad today. I especially felt this a lot of times when I was in residency because of some of the procedures we had to do on kids, some of the places we rotate. It's tough. The kids are just really sick, and you're having to do things to them all day long. And it's hard to explain that to a 3-year-old. And so stepping back and saying, how do we provide our care in the smartest way possible, but do it in a way that's medically safe? And there are resources, even though it feels like there's not. These are the 6 principles of trauma-informed care. I'm not going to spend a whole lot of time on them, except to point out, do you feel this way when you go in to get medical care? I'd venture to say most of us have probably not had this experience. And I'd venture to say we may or may not be able to provide this on a regular basis in our own practices because of all the barriers we talked about before with billing and time and stresses, et cetera, et cetera. But this is the goal, to really look at each patient as an individual and what their particular needs are. This is a survey that I just thought was really interesting. It was done on a group of like actual trauma surgeons and their staff, so the trauma nurses, the trauma respiratory therapists, PTs, et cetera, et cetera. What they found out, they asked them several questions about their views about trauma-informed care and if dealing with trauma actually impacts medical care and medical outcomes. And what they found was most of them, especially if you look at questions 1 through 5, agree that if you don't deal with the mental health or the behavioral health of a patient, you're not going to get as good of a health outcome. So I don't think it's a knowledge problem. But the last question is interesting because it says, I have colleagues I can turn to for help with a patient experiencing significant traumatic stress. And you can see that many of them agree, about 57% agree with that, but then about another quarter don't feel like they have any resources they can turn to. So that's kind of what we want to work on addressing, especially within our hospital setting, helping create some links so people know who to turn to and go to. The other thing that kind of gets overwhelming with this is you start thinking about all your patients all day long. How am I going to do this? This is going to take an enormous amount of time. The good thing is most people handle their stress well and are resilient and are going to be fine. That's the bottom group. We just give them education, let them know we're there, and be available. The middle group is more the targeted kids, and this is going to be the kids that have more risk factors. There's domestic violence in the family, or dad just lost his job. They just recently had a hospitalization. Those are the kids that you need to be kind of watching a little more carefully and maybe screening a little more. And then at the top are the kids that are going to need the intensive care that we're going to need to get into behavioral health. So you're not going to be referring 50% of the kids you see to behavioral health. So don't worry that you're going to get into the morass of trying to manage that. This is just another way of looking at it. I thought it was interesting kind of looking at who would be involved in the care. Universal, it's really going to be the primary care docs, nursing, child life, social work, care coordinators, kind of the usual team that does hospital care and primary care. Targeted families that are having risk factors and increased stresses. Again, it's going to be similar team, maybe some counselors getting involved at this point. And then the clinical level, which is the kiddos that are going to need significant therapies, we're going to be using psychology, psychiatry, and then other support services. So again, you're not going to be needing to do this on everybody that comes through. So at this point, I know you guys are kind of like, well, this is really vague. I don't really know what this means. So I wanted to just give you some examples. I'm not going to go through every one of these. But what is the tangible effects of trauma-informed care? And again, a lot of this is common sense, and it's stuff we should do, but we're tired, we're burned out, we don't have enough resources to get our jobs done, and it starts to slip. So these are just good reminders of stuff that we can encourage in ourselves again. And you know, it's having a nice physical plant, it's having good signage, it's having you know, the whole issues with bathroom signage now, things like that, so that a certain group doesn't feel alienated in your environment or your clinic. Staff appearance, again, good hygiene, looking professional and being easily identifiable, which is always an issue, especially in hospitals, because 32 people come in your room in a day and you don't know who they are half the time. Staff behavior, again, common sense, be nice, make eye contact, tell people about delays, as much as you can, communicate. Organizationally, it is basically an organization that recognizes there's trauma and does things to try and offset that. The one that kind of hit me when I was reading this list is a clear organizational plan for dealing with behavioral crises. I've worked in many places where we did not have that, and they would happen and it would be a disaster, and then everybody was upset, and then we went on to the next thing. So something to think about. The other one is discrete areas for calming or crisis management are identified. Because trying to talk to somebody who's suicidal in a clinic with screaming kids getting shots is a little odd. So just thinking about things like that. Treatment considerations, basically it's working with the patient instead of on the patient. Talk to them about what their goals are. Their goal that day may be to not use heroin. And your goal is to try and get their asthma under control. It's probably not going to go the way you want. So again, just taking that time to step back and work through that with them. The other thing that I found while doing some research on this was just a handy little tool. This is more specifically for medical trauma, like when a child has come in for a procedure or they're traumatized by coming to the doctor's office or something like that. We all know our ABCs, which are the most important and we need to do first. But then when you can take a chance to breathe, think about your DEF, which is distress, emotional support, and then the family. And it just gives you tips of things and cues of things to look through and to think about when you're working with families that are under stress or have a lot of social issues that you're going to need to work through. I'm going to turn it back over to Funda at this point.
So this goes back to being cognizant of being trauma-informed in your practice. So in some ways, we're really good at this, right? We know kids are going to have painful procedures. We have child life come up. We have the parents be there when they can. And in some ways, even though we know what we should do, we have difficulty with implementation. For example, we know that the most important thing for these kids is that relationship with the primary caregiver. And the most acute children, we admit them to the psychiatric inpatient unit. And the first thing we do is say, well, mom and dad can't stay here. And you have phone time between 4 and 6:30, and there's visitation for an hour and a half in the morning and an hour and a half at night. So, and we know, right? We know that that's not what we're supposed to be doing, but sometimes the system limits us. So it's the stuff Laura talked about. It's having quiet places for these kids, making sure they can talk to the supports in their life, because that's ultimately what's going to happen and help them. And then also understand that even though we are helping, this could be very traumatic for these kids and the families. So we're often in a rush, but just taking a moment to pause and understand that when patients and families are being difficult, that lots of times their brains are wired differently. This is not an intentional slight against you, that they're purposely trying to make your day difficult, that they're never going to learn, all of those kinds of things that we tell ourselves. That's not what's going on here. People don't usually wake up and say, like, how can I mess things up today? People are trying to have a good day, and they're doing the best that they can. So it's important to remember that. It's also important to remember that with each other, right? So we hear this all day. We deal with the frustrations of the system, of not having enough resources. We deal with the drama of the EMR going down every 30 minutes and not being able to send scripts, right? And we know that maybe we're not helping these families as much as we could, and that's really hard. And so we have to acknowledge that in ourselves and in each other. So when someone comes up to you and says something kind of snippy and short, of saying like, hey, maybe something's going on with them, right? Maybe this isn't about me. So really taking the time to understand other people. When we are not able to do this, that's how we end up in compassion fatigue and burnout, right? Because then you feel like nothing I'm doing is making a difference. This is just really, really frustrating. But if you take a moment to think and focus on that relationship, if you maybe just listened to that patient today and gave them someone supportive that they could count on. If you're the person that says, I'm going to be here at 5 and you're there at 5, that is a big deal to these kids. So have compassion and patience with your patients as well as each other. It's really important. So here, back to the case.
Before I dive into the case, the other thing that comes up a lot when we talk about this is we're basically giving the patients excuse to act poorly, and we're going to have chaos because there's no rules. So the one thing I want to emphasize is trauma-informed care does not mean there aren't rules, and trauma-informed care does not mean that patients don't have responsibilities. It means that instead of when they come up to the front desk and they're 30 minutes late, and it's the third time they've done that, that instead of us going, we cannot see you today, that we take a minute, we say, hey, this is the third time this has happened. Is there something going on? Do you need help with transportation? Is there an issue with whatever? Instead of just shutting them down and heading out the door. And again, that's hard. It takes time, it takes resources, and you're not going to be able to solve everything. And there are going to be patients where you just have to simply draw a line and say, if you are not able to be on time for your appointments, then we are no longer going to be able to see you. But at least have that discussion with them instead of kind of doing it in the background. The second thing is, this is not easy to do. Yesterday, as I walked out of a teenager's room, I was rolling my eyes because of this teenager's continual issues. But again, I have to stop. I have to say, all right, they have had a really screwed up life. Take it back a step. and where are we going with this? What can I do to help this patient out? Even though right now I just want to scream and tell them to go do whatever they're going to do and come back when they run out of medicine. But it does give you, if you can give yourself that perspective, it really does help decrease frustration a lot of times. So anyway, back to our case. So obviously I think we know how interacting with the healthcare system caused trauma for this patient and this family. Basically the trauma was kind of benign neglect. We essentially weren't able to do follow-up well, and we weren't able to get them the care they needed quickly. But in some cases, the medical care is much more invasive. And so in those cases especially, those of you that do hospital work, those are the kids you need to make sure have follow-up, and that their pediatrician knows, you know, they had 2 bone marrows done, and they're a little freaked out about everything right now, because it's important for their pediatrician to be able to follow up on that. Secondly, what could have been done differently using a trauma-informed lens? I think we've kind of gone through that. I think there's a lot of things we can do differently. Again, we're not going to change everything in a day. We're not going to change everything in a year, but we can start making small changes, especially to the way our system works. How does the healthcare system cause trauma for providers? Again, be gentle with each other. There's days when I know the nurse that does this just stepped out, but she'll be like, do you need a minute? Do you need to just take a minute? And I appreciate that. It's good feedback for me. You need to bring it down. But, you know, give each other those safe places to just take a minute, take the pager from them, let them go get a Coke or water. Water would be healthier. And other staff. I mean, our poor referral coordinator will just call me sometimes and be like, if I have to call this family one more time, I'm going to kill you. So again, just remember that that interaction is occurring all around us. So what's happening at PCH in a trauma-informed care setting? So currently, psychiatry, the inpatient unit is working on something called the sanctuary model. It's an approach to organizational structure and the way you approach patients to provide trauma-informed care. They are doing some studies on that, and they're also ACE screening all the kids that come in to the unit and looking at how that's impacting on their care. General pediatrics and adolescent clinic, we're now screening at well checks yearly starting at 1 year of age. This is a baby program, so we're just starting out and things will probably change, but we've also been able to secure funding for a LCSW, Leslie in the back there, who is providing counseling for families that need it in Gen Peds. It's kind of a bridge counseling system. We're not going to be taking over the world with counseling, but we're going to do what we can. And then we also have a wellness nurse who's going to help with some of our more medically complex families that have a lot of social challenges. So we're going to see how that works. If it's something we can get to function, we'll pilot it in community practices and see if we can actually figure out a way to fund this with the insurance companies. We have a trauma-informed care work group for the hospital. If any of you are interested, please let Funda or I know. We'll get you the invites. We are a dedicated, ragged group, and we're trying to figure out ways to start looking at PCH and how do we do this a little differently, and how do we support each other a little bit differently. Homeless Youth Outreach, where I work, we're doing ACE screening. We also have a lovely grant that has provided 2 LCSWs, Angelica's one of them, who save my life on a daily basis, because when they're suicidal, I can have somebody else come in and help me, because that is really hard to deal with when I'm trying to see other patients. But in all sincerity, it's been wonderful. Having behavioral health integrated into our visits, they actually come in our visits with us and will hear everything the family's telling us while I go out to staff or write orders. They can talk to the family, do basic quick stuff, and then set up follow-up for the family, which is amazing, especially for our population. And then the Center for Child and Family Safety has a program. It's called Cole's Mindful Me. They work with schools to talk about trauma-informed care and how to deal with all of these behavior issues at school, because, you know, we get them for 5 days, they get them for a year, and imagine dealing with some of these behavior problems all year long in a school setting. So that's what's going on at PCH. To encourage you, I know everybody's going to roll their eyes. The insurance companies are beginning to listen. They are interested. They are coming to us, asking us about this, and how do we integrate it in? How do we start talking about this and figuring out payment structures for it? There are people working on that. So it's not going to be yet another unfunded mandate, we hope. The other thing that has been very interesting is Governor Ducey and his wife have taken this on as a particular issue for them due to some family that had foster children. They have decided that this is something that they're really going to work on, and so there's a governor's panel about trauma-informed care and how do we use this more effectively with the kids in Arizona. These are just some things I asked some of the behavioral health workers I work with and some of the child life workers, things that they would recommend having seen us work. What are some things that, just simple things that we could do? So just take a look at them. I don't know if any of these strike you. Maybe try working on them over the next week. Just see if it causes you to run behind or if it makes you feel less frustrated when you're doing your work. For me, this all just makes sense, and it's made taking care of patients a lot easier when I look at them this way, because I'm not constantly bashing my head against the wall about why do they not take their medicine. And it gives me a place to start targeting when they're not taking their medicine instead of just being frustrated. Here's some other things. With that, I'm going to go ahead and sum up. Are there any questions anybody has about this? Again, I know it's a vague topic and it's a little bit hard to get your hands around sometimes, but yeah. Right now, do you want to come up? Right now, the studies are ongoing because it's obviously a long-term outcome. What they have been able to find is that there's increased satisfaction on the part of patients and then providers when they start kind of looking at this, but there aren't long-term outcome studies yet. There was one started recently in San Francisco by a group that does a lot of work with this, that's looking at medical outcomes and then also biomarkers to see if there's something we can actually draw and track on people. The other thing is the original study that was done in '98, they've done some outcome studies, but again, the period of time hasn't been long enough on some of those to see the decreases in certain health problems.
And they're not really looking at interventions. They're looking at the absence of the ACEs or the lower ACE scores and the better outcomes with those patients. But we are going to be looking, as we've only just started the rollout of the sanctuary model on the inpatient unit, but we will be looking at things like decrease, hopefully, in restraint and seclusion rates, readmissions to the hospital, and medications, misdiagnoses, those types of issues in our patients, as well as employee satisfaction. So a big part of trauma-informed care is how we see each other as well, and making sure that the employees and the staff feel safe and heard.
But it's a good question. We don't have that number to take to admin yet, so.
So the sanctuary model is one of the models for implementing trauma-informed care. So it was started by a psychiatrist out in Philadelphia at Friends Hospital. And so it initially was done in inpatient psychiatry, but then now it's used in other hospitals. So it has 4 pillars that it looks at. You may need to help me remember them. So one is the trauma, right? Being trauma-informed, that trauma impacts our behavior. And then there is a toolbox for kind of interventions and things you can use to help these families and the patients. There's 7 commitments, so those include some of the things that were outlined in trauma-informed care, like a commitment to democracy, a commitment to learning, a commitment to safety, and then there's 5 or 4 others. And so it takes all these things and gives you an outline for how to implement this change. It's a slow process because you're really changing the culture. So like I said, we're just beginning. So like one of the emphasizing things is safety. So you're not wearing your safety plan. So we have safety plans, right? So if I'm feeling stressed out, I do my 4-7-8 breath. I play Candy Crush on my phone. I shop online. So yeah, it's really nice, right? So the idea is in a trauma-informed community, the kids have safety plans, but they're not the only ones that get upset, right? We get upset too. So Laura can come to me and say, hey, do you want to just do you want to go play Candy Crush for a minute? Or the kids can come up to me and say, oh, Dr. Bachini, maybe you should plan a vacation, because they can tell that I'm getting upset, right? It involves things like community meeting, of learning to recognize your feelings. How are you feeling today? Not how are you doing, right? Because the answer to that could be good, fine, but how are you feeling? Because one of the problems that kids that have been through trauma have is they have difficulty being future-oriented, so practicing things that are grounding, letting them check in with their emotions, and then, who can you ask for help? What are your goals for today? And again, all the things that we do with the kids, we do with each other. Yeah? So it's a lot of that. So and that's probably a whole nother Grand Rounds presentation, but the mental health system in Arizona runs differently than in other states. It's a carve out due to a lawsuit. And up until this year, the way it worked was that all the different agencies, first of all, we have the regional behavioral health authorities. That's what we had, right? They would get their money up front. And then if they didn't spend it, they would keep it. And every regional behavioral health authority had contracts with different service providers. Everyone had like a CEO and a medical director, and there was a lot of money spent on administration. And now they have to perform the service to get the money. And so now there's no services. That's causing a lot of backup as we're adjusting to that model. So that's like 10 seconds of a really long, involved answer.
And what it basically boils down to is we don't have the services right now, and that's not going to go away in the next year or two. But we as primary care can learn some new techniques, and there's things we can do in the office. Again, you got to keep it within 15 minutes, you got to keep it organized, et cetera, but there's things we can do. And that's a whole nother talk that maybe we can do someday. But I mean, even Angelica's shown me some quick things that I can do with a kid just to get them calmed down so that they're not screaming at me and slamming doors. So there's things we can do as primary care docs to move things forward. Okay, I think our time is up. Thank you so much. We appreciate you listening.